In this talk, we'll be covering various airway topics that will be useful to someone who's relatively new to critical care. We'll be discussing intubation, tracheostomy, as well as troubleshooting, and going through some situations you may be faced with when you start working on ITU. Many of our patients are intubated, and the most common way this is done is orally with the cuffed oral endotracheal tube. These obviously come in various sizes. The main differences are the internal diameter, and also the larger the internal diameter, the longer the tube will be. The way the size of the tube is selected is generally based on the size of the patient, as well as any airway abnormalities or swelling that we think may be present. We primarily put them in for respiratory and neurological indications. So if someone's in respiratory failure or is unconscious to the extent that they're not protecting their airway. And you can divide these into elective and emergency intubations. So in critical care, we may choose to intubate someone electively if they're due to go to theatre, or we're anticipating a decline that might require intubation, because often it's better to do this in a more controlled and planned manner than a crash intubation in somebody who's in established respiratory failure. It is a high-risk procedure, and it does require specialist staff and equipment. Now, because it's high risk, it's not without its problems. And in 2011, the NAP4 study was a nationwide audit of major airway complications in the UK. And what it found was that 25% of all major airway complications occurred in ED or ICU, and that a lack of capnography contributed to 70% of ICU deaths. And in terms of the predominant cause of morbidity and mortality in ITU, it was found that displaced tracheostomies were to blame. But importantly as well, it noted that needle cricothyroidotomy success rate was only 40% compared to almost 100% with the scalpel technique. So as you can see, we're doing a high-risk procedure in patients that are complex and critically ill in an environment that is not necessarily designed for this. So in theatre, there is a skilled assistant, there's a trolley that tips and moves in any way you want it to go, and all the kit and equipment you might want, whereas ICU is slightly different. So that sort of explains why the rates of complications are so much higher, but also highlights how important it is that we have a plan and a practice in this procedure to ensure the best outcome for our patients. The lack of capnography nowadays is unforgivable, and it's mandated that all patients who are having an airway intervention have waveform capnography. Now, how do we improve safety? Not only do we increase training, we improve equipment, we get better at using the drugs we use for induction. It's also noted from taking this from the airline industry that checklists can help because they reduce the cognitive burden on an individual, and they're also a safety layer against forgetting a critical step or a critical piece of equipment in what can be a very pressurised situation. And the way this is manifested in most hospitals is through the use of LOCSIPs, which are essentially a checklist and help highlight the important steps and kit and equipment that you might need for that procedure. So this is an example of an intubation checklist from the Intensive Care Society. Now at Aintree we use a LOCSIP, which is very similar to this, but it is set out slightly different. But the sort of idea behind it is the same, in that we want to prepare the patient first of all, so we need to make sure we have good IV access, we have them in a good position, we've assessed their airway and anticipated any difficulty that might be there. We need to make sure they've been pre-oxygenated adequately, so this would be for at least 3 minutes, using 100% oxygen, usually through a face mask attached to a water circuit. However, if they're on CPAP or an IV, leaving them on that on 100% would be a reasonable alternative. We don't have any way of measuring end-tidal oxygen in ITU, whereas in theatre they do, so you can make sure that your end-tidal oxygen is over 85% there, but here we just have to rely on time. And then consider the use of nasal oxygen. So nasal specs turned up to 15 litres when the patient's asleep will provide some passive oxygenation and prolong your safe apnea time. And then we also need to optimise the patient's state. So we need to recognise that not only is putting the tube in potentially difficult, but the stress that that places on the patient's physiology can be very dangerous. So do we have adequate fluids, vasopressors and inotropes ready to hand? Have we aspirated the NG tube to make sure the stomach's empty? And do we need to consider a delayed sequence induction, which allows a small amount of sedation, usually with ketamine, to be given to allow the patient to become more compliant and therefore permit safe pre-oxygenation? And we need to think, are they allergic to anything? All the equipment needs to be checked, so we need full monitoring. We need to make sure we have all our equipment, and a lot of this is making sure we have spares, so making sure that we have a tube and a spare tube, and that both cuffs are checked, making sure we have a range of tube sizes available, make sure we have 2 laryngoscopes to hand. Now our first choice at Aintree is the McGrath video laryngoscope for all intubations, but there are direct laryngoscopes in the airway trolley next to the bed that when you're intubating, that would be your backup. A bougie must always be available. Your suction must be close to hand and turned up to maximum suction, and then you must also have your backup. So you must have supraglottic airways, oropharyngeal airways, and then your difficult airway kit, such as fibre optic scopes, which are available in all areas on the unit. You also need to think about what we're going to do if we can't get the tube in. So we need to have the ability to perform a surgical airway, and we need to have the kit present to do that. We need to make sure we have drugs to put the patient to sleep and induce muscle paralysis, and also make sure that we have something to keep them asleep afterwards. Preparing the team is important, so everyone needs to know who everybody is and what their skills and abilities are. So often it will be a case of introducing everybody, even if you know everyone. It's helpful to have the names refreshed and their job roles highlighted. Particularly important to identify who the first and second intubator is, who's doing the drugs and who's being the assistant. An important point for Aintree being a trauma centre is the use of manual inline stabilisation. Is their spine cleared, and do we need to keep intubating them with their spine immobilised? Who do we call for help? Well, at Aintree, as consultants, we're fairly present all the time, so we'll probably be there, but we need to think, who do we call for help? So if we're not there, obviously you're going to need to call the consultant that's on call. You might think about, is anaesthesia available? Are they going to be able to help and attend if needed? And then preparing for difficulty. So can we wake the patient if intubation fails? Well, universally the answer to that on ITU is no. We need to work through our plans A, B and C. So plan A is obviously the patient goes to sleep and they get intubated in the standard way. Plan B would usually be a supraglottic airway or face mask ventilation with some method of getting a tube in after that via a fibre optic intubation. And then plan D would be front of neck. Now the speed that you go through that process will depend on the patient and their oxygenation and physiology. This is another example of an ITU intubation checklist. It's what we used to use when we did things on paper. And it's essentially very similar to the ICS checklist I've just shown you, but there's slightly more attention showed to making sure that we have each tick for each piece of procedure that we might need. It's important to note that nobody dies from a lack of plastic in their trachea, they die from a lack of oxygen in the blood. There's been countless problems and disasters over the years where people have focused on getting the tube in, and meanwhile the patient's becoming very hypoxic, and in some cases has led to deaths. So it's important to, yes, we need to get the tube in, but we also need to maintain oxygenation. So it's important to talk through your intubation plan so that that's clear to everybody. Now, Difficult Airway Society have difficult intubation guidelines. And a lot of these are based on elective intubation in theatres. So, for example, you try to intubate the patient and you can't, so you put a supraglottic airway in, and then it's telling you to stop and think, and do we need to wake the patient up? Well, I to you, that's never an option. So you're going to end up proceeding quite quickly through your difficult intubation flowchart and getting to surgical airway. Now, they can be chaotic, these intubations. despite it being an intensive care unit, intubating someone in ITU is actually relatively uncommon. It's not a procedure that the nurses will see every day, so there will be a lot of unfamiliarity with what's going on, and so it can be a bit crowded and chaotic because everybody wants to come in and see what's going on. So therefore it's important that you have a plan of who's doing what and make sure that the room is set up to allow that to happen. The kind of minimum number of people that you would need to intubate someone really would be 4 people. You need someone to give the drugs and be a second intubator. You need someone to be first intubator. You need someone who's there passing equipment, and then you need a runner who can go and get stuff when you need it. More people than that is better, but we would consider 4 to be the absolute minimum. Now, I call this the old way because it's rapidly becoming fairly obsolete with the advent and widespread use of video laryngoscopy. But a direct laryngoscope, in this case the Macintosh blade, which would be the most commonly used, is essentially a blade that allows you to displace the tissues in a way that allows you to see the larynx. We use the Cormack and Lehane airway assessment guidelines, airway assessment grading, to describe your view essentially. So on the bottom there you can see box A would be a grade 1 view, B would be a grade 2 view where you can only partially see the glottis, C would be a grade 3 view where you can only see the epiglottis, and D would be a grade 4 view when you can see none of those structures. And the difficulty with intubation will obviously increase as the view worsens. But the new way, so we have McGrath video laryngoscopes everywhere now, and they're very good. They are a standard geometry Macintosh blade with a camera and a light source on the end, so you can see what you're doing with the camera, and it's very useful for seeing round the corner, so you can get a very good view of the larynx without using as much force as you would with a standard blade. But you can also use them to intubate the patient normally with direct view. Now, surgical airway, the intubations on ITU and out of theatre, intubations like in the emergency department, are high risk for a failed intubation because the patients are more unstable, they're in a worse position, and you don't have the time to mess about with other pieces of kit. So if you have a failed intubation, there's a high chance that you'll end up progressing to emergency front and neck. And as NAP4 showed, the use of needle cricothyroidotomy failed a lot of the time. So the procedure that's suggested now is the scalpel bougie cricothyroidotomy, which you only need a scalpel, you need a bougie, and you need a size 6 endotracheal tube. And essentially, to do this, you're going to hyperextend the patient's neck by shoving a pillow under their shoulders. You're going to feel for the cricothyroid membrane by performing what's known as a laryngeal handshake, where you use your left hand to hold the larynx and thyroid cartilage, and then your index finger to palpate where the cricothyroid membrane is. You're going to make a sort of a 2 to 3 centimetre incision in the skin down through the cricothyroid membrane, what's known as cutting to air. So you're going to get air coming out then, and that's when you know you're in the right place. And the Difficult Airway Society advocates then rotating the blade 90 degrees to create a little triangular window that you can post your bougie through. In my experience, this is probably not going to be helpful in everybody because there will be a lot of blood. So once you've made your hole in your cricothyroid membrane, one alternative advocated is to stick your finger into the trachea through that hole. Then you can palpate the tracheal rings so you know you're in the right place, and then you can slide the bougie down the side of your finger. Once that's done, you can then insert the tube over the bougie. The bougie must go down past the clavicles, otherwise you may be in a false passage. If it goes down past the clavicles, it probably is less likely. Once the tube's in, you're going to confirm position in the usual way using waveform capnography, as well as clinical signs such as chest movement. Drugs, well, the predominant thing we tend to use is some form of sedation and a muscle relaxant. Intubating without a muscle relaxant is very difficult and makes the whole procedure much more difficult. So we would usually always use a muscle relaxant. The choice of drugs and muscle relaxant will depend on patient factors. Those of you that have worked in theatre and seen induction doses of propofol in healthy elective patients, we don't use those doses. If you give someone on ITU 20 mils of propofol, they will probably have a cardiac arrest. So we tend to use an opiate, either alfentanil, fentanyl, an induction agent, which the choice would depend on the clinical circumstance, but we commonly use things on here would be propofol, ketamine, thiopental, some kind of benzodiazepine like midazolam, and then rocuronium in a rapid sequence dose, which should be 1.2 milligram per kilogram of ideal body weight. For most people, this works out at about 10 mils, which conveniently is what size the ampule is. And then it mustn't forget the post-intubation sedation, because otherwise your induction drugs will wear off. The patient will still be paralysed, but they'll start to wake up, which is very unpleasant. Tracheostomies we do a lot of at Aintree. They're useful to help in weaning patients from the ventilator. They're usually temporary, but occasionally they might be permanent. So if a patient has a severe brain injury and isn't recovering to the point where they can protect their own airway or manage their own secretions, it may well be permanent. And the benefit of tracheostomies is they allow provision of invasive ventilation without the use of sedation that you would need to tolerate a endotracheal tube. So therefore the patient can be awake, they can participate in rehab and physiotherapy, they can cough more effectively, they can have a nicer experience by being able to interact with their relatives and family, but they can still have ventilatory support through the ventilator. The two techniques you can use to put these in would be surgical or percutaneous. Percutaneous tracheostomy we would do on ITU, whereas surgical tracheostomy they would go to theatre to have that done. The vast majority of our trachees are done percutaneously. The benefit of a perc trachea is you get less risk of infection. You have a smaller hole, so it closes up nicer when the trachea is removed, and there's less bleeding risk if you do it carefully. This is the technique we would use. All tracheostomies are a two-person technique because you need someone at the top end with a bronchoscope down the tube to position the tube properly and ensure that you can visualise your needle and wire entering the trachea where you want it to. But it's a seldom a technique like many procedures we do where we put a needle into the trachea and a guide wire down that needle, and then there's various stage dilations, the mainstay being the sort of blue rhino horn that allows a large hole to be made, and then the tracheostomy can go through that. Once the trachea's in, you're going to very quickly confirm position the same way you normally would, with waveform capnography and also direct visualization with the bronchoscope. Once a patient has a trachea in, they need to have a safety sign above their bed, and the importance of this is it tells you what kind of trachea they have. So if there's a problem with the trachea, you know what's going on. Particularly important where a patient has had a laryngectomy, because they do not have an upper airway. So if you're trying to re-intubate them from the top end, you're not going to manage that. Similarly, a commonly used technique for patients who have had maxillofacial surgery that come back from theatre with tracheostomies is the Bjork flap. And this is where they make a flap in the trachea and secure that flap open with some sutures that they then usually tape to the patient's chest. And the benefit of that is if the trachea falls out, you just need to pull the sutures and it will reopen the hole. There's also space for noting if they're a really difficult airway. Different attachments we put on trachees. So the most common one we would use is a Passimure valve, or you might see this abbreviated to PMV. It's essentially a one-way valve, so it allows exhalation through the upper airway, which then allows the patient to speak, but they will inhale through the tracheostomy. It's important to note that the tracheostomy cuff must be deflated when you use a Passimure valve, otherwise you're essentially preventing them from exhaling, and they will very quickly asphyxiate. Swedish nose is another thing you might see used. This is essentially a piece of plastic with some material in that humidifies and traps moisture, because you're not breathing through your upper airway, you don't have the normal airflow through your nose that would humidify the air normally. Now, troubleshooting. I'm going to go through some common emergency situations. The important thing to remember is you need to get help. So we wouldn't expect anyone to deal with a tracheostomy emergency single-handedly. So you're going to pull the emergency buzzer, you're going to fast bleep people that you need. So that could be the airway doctor, which usually would carry bleep 5060, or the anaesthetic reg would be bleep 2172 if you're out of hours, for example. And you need to be calling the ITU consultant to come and help. The first principles are the same. So ABC, apply 100% oxygen. If you're not sure, give 100% oxygen to the face and to the neck. So common problems we might see in airway problems is the tube falls out. There's a cuff problem with the endotracheal tube. The tube's in a bad position, or the tracheostomy tube is blocked or displaced. So if the tube falls out, this is clearly an emergency. You need to get help quickly. You need to oxygenate the patient, so you need to apply 100% oxygen. The patient may be breathing, in which case you can support them with just a 15-litre non-rebreather bag, or they might be breathing but inadequately, in which case they might need some help with some mask ventilation. If they're apneic, obviously they need ventilation, or they'll die very quickly. So you could achieve this through a face mask or by putting an LMA or an iGel in temporarily. And then we're going to need to prepare equipment and drugs for reintubation and then reintubate the patient. Common cuff problems, a cuff herniation. So if the tube migrates out slightly, what you often find is that the endotracheal tube cuff will be sitting at or above the cords, and this will lead to a leak despite adequate cuff pressure. So the nurses will keep inflating the cuff, they'll be checking the pressure, telling you the pressure's fine, but there'll still be a leak coming out of the mouth. What's important to note here is you cannot simply push the tube in further, it won't work. Often the tube will be warm because it's inside the patient, it will be malleable. When you push it in further, all it's going to do is arch in the mouth. And if it's in a precarious position within the larynx, you could actually displace it completely. So it needs to be manipulated under direct vision. So the patient needs to be adequately sedated, paralysed, and using laryngoscopy, the tube either advanced under direct vision or changed to a new tube. Commonly, I would suggest if there's a problem with the cuff, we should just change the tube so it doesn't happen again. If the cuff isn't holding pressure and it keeps deflating, this will cause a leak. The most common reason for this is the cuff has been caught on the teeth during intubation and there's a small hole in it. The only solution to this is changing the tube. If the tube is too far in, it will tend to go down the right main bronchus, just because of the angles that the bronchi sit at. Most common depths you find is 21 centimetres in females and 23 centimetres in males when you measure the tube at the teeth. Obviously this will depend on the height of the patient as well as any other anatomical abnormalities. But what you'll see is you'll notice there's no air entry on the left side. The patient will rapidly desaturate and become hypoxic. If you do a chest x-ray, it becomes very obvious, and you can see there that the endotracheal tube is very far in and is advancing down the right main bronchus, and this has led to partial collapse of the left lung. So you need to withdraw this tube. Ideally, you do this under direct vision so that you can check you're not pulling it out completely. You're going to make sure the patient's adequately sedated and has had some muscle relaxant to allow reintubation if that's required. And you can have all the equipment ready that you might use if you are going to intubate them fresh. Once you've withdrawn the tube, you need to make sure it's still in the trachea using waveform capnography and clinical signs to make sure that you've got bilateral air entry. It's also worthwhile getting a chest x-ray to check position and lung re-expansion. Now, tracheostomy problems can become very serious very quickly. So if a trachea is blocked or displaced, you need to be getting some help. And we need to know as a priority whether they have an upper airway or not. If they don't, for example, they've had a laryngectomy, there's no point trying to reintubate from the top end because it won't be possible. The majority of our patients will have an upper airway, though it might be a very difficult airway, particularly if they've had maxillofacial surgery. So if there's a problem with the tracheostomy, we need to get help quickly. You're going to use your first principles of ABC, and you're going to look, listen and feel at the mouth and tracheostomy to establish, are they breathing? If they are breathing, you can apply high flow oxygen to both the face and the tracheostomy. If they're not breathing, you're going to proceed to resuscitate them as you would normally. You need to assess your tracheostomy patency. So if there's any valves or caps on it, like a Passy-Muir valve, for example, you're going to remove that. You're going to remove the inner tube, if there is one present, because that can be blocked. And you're going to check, can you pass the suction catheter? So if you can pass the suction catheter down, the tracheostomy tube is patent. So if you've got the suction catheter goes down and there's end-tidal CO2, the tracheostomy is where it should be, and there must be another problem causing the patient to deteriorate. If you can't pass the suction catheter, you're going to deflate the cuff, and this will allow some airflow past the tracheostomy up into the upper airway, and this may help improve things if the patient is breathing for themselves. If it doesn't improve and you've got to this point, you need to take that trachea out, and then you're going to reassess them and manage them from the top end where possible. So for example, simple oral airway manoeuvres like bag mask ventilation whilst you're preparing new kit to reintubate, and also if that's not possible, you can try and ventilate via the tracheostomy stoma, though with a percutaneous tracheostomy this will be very difficult. So as I said, 100% oxygen. If in doubt what their anatomy is, give oxygen to the face and the neck. You're going to assess the patency. If they've got an inner tube, you're going to take it out. Can you pass the suction catheter? If you can't pass the suction catheter, you're going to deflate the cuff. If that doesn't help, you're going to take the tracheostomy out and re-oxygenate from above, and you're going to prepare for an emergency and probably quite difficult reintubation.